জি ম্যাম। আসসালামু আলাইকুম ম্যাম। আমরা লাইভে চলে এসেছি। আপনি শুরু করতে পারেন।
Okay, so let's start our today's session. Bismillahirrahmanirrahim. We are going to start at this very nice morning with the rest part of the miscellaneous chest X-ray. We are familiar with some issues regarding this part of history. We will learn today how to detect the COVID-19 X-ray, how to read it, and what are the findings today we are going to learn. The COVID chest X-ray findings we are going to discuss. The X-ray chest usually shows initially ground glass appearances, usually bilateral, even in early stages of presentation. Later on, this ground glass appearance progresses and there is consolidation noted in both lungs, especially the lower lobes, particularly posterior segments, and fundamentally there is peripheral and subpleural distribution. Initially, when COVID came on the situation, we used to get a peripherally based consolidation, and that was the typical presentation in COVID pneumonia. Later on, there was found an association of the COVID-19 pneumonia and pulmonary thromboembolism. And peculiarly, the pulmonary thromboembolism has got the similar radiographic findings as the X-ray of COVID pneumonia. So, the association of the COVID pneumonia and pulmonary thromboembolism is remaining a challenge to be differentiated. So we have to mind that the COVID presentation as peripherally pyramidal shaped consolidations are also important presentation of pulmonary thromboembolic patient. There may be association, but dissociation you should not forget. The lesions are seen in 50% patients in first 2 days in CT scanner and later in X-ray basically. And the lower lobe predilection is an important part also. And the next few days it progresses and gradually diffuse. There is associated septal thickening and that's why we can get the band shadows in on the background of ground glass opacity. And in the CT scanner, we used to describe such presentation as the crazy paving pattern of CT findings. This is an X-ray, part of X-ray seen here. And the lower part of the X-ray, the upper part is also normal. And you see this as a clear lungs. This patient has got clear lungs. Later on, whenever this patient is developing COVID-19, the ground glass opacities are seen at the bases, at the periphery of the lung. And you see the band shadows here and possibly here and here. And you see the seriously ill patient has got the central lines and the emergency catheterization. Later on, there is consolidation progresses towards the upper zones also. The part is seen here. The X-ray findings in the COVID-19 patients may be categorized as no X-ray findings in mildly ill patients. There would be a negative chest X-ray. In up to 63% of COVID pneumonic patients, they may have got no pulmonary changes, particularly in the early stages. The ground glass opacities are gradually associated with consolidation and peripheral linear opacities. Ground glass opacities are usually peripheral and is increase in density of the lung. There is preservation of the lung markings. This is the difference between the ground glass opacities and the consolidation, pneumonic consolidation in COVID-19 X-ray. The ground glass opacities are the confluence of the very early viral components, and thus it is just increases the density of involved lung, and there is preservation of the lung markings you can see. And these ground glass opacities are superimposed with pneumonia. Then there is loss of lung markings. And the septal line thickenings are presented as peripheral band shadows. Consolidation is loss of lung markings I have mentioned. The other important things we should not forget in the association of COVID and pandemic situation, that the comorbidity changes, those which are potentially important for the chest X-ray in seriously ill patients, may be obscured by the COVID lung presentation or may be overlooked in COVID positive X-ray. Because such ground glass opacities are also present in serious lethal states like myocardial infarction, resulting in pulmonary edema. So, the comorbidities you must have to go through for the patient, and there is a specific observation of the chest X-ray should be done, and the history of the patient is important, of previous or recent attacks of any abnormal issues that may result in potential comorbidities and lethal outcome. Surprisingly, this COVID-19 X-ray and the COVID-19 patients really don't have a fusion, adenopathy, or pneumothorax. This is very rare, 1 to 3% only. So, what is the conclusion? I must go through that again. There is peripheral pleural-based ground glass opacities. The initial presentation may be associated with septal lines presenting as a dense linear shadows. We used to say band shadows on the ground glass opacities, and on the next follow-up there is increase in the area involvement, and progression of the disease results in diffuse involvement of the lung, especially the lower lobes and the posterior segmental distribution. And whenever there is superimposed consolidation, loss of lung markings is a milestone to be present with COVID pneumonia. What are the other differential diagnoses? Those are atypical pneumonia like MERS, COVID infection, and SARS or other. The pulmonary aspiration, pulmonary edema, lung cancer, and pulmonary inflammation like eosinophilia, vasculitis, and hemorrhage can present such type of X-ray findings. What about CT? And the CT coronal section is depicting practically an X-ray. See that this is this just the coronal image of the CT is presenting as the differential densities. The densities are not uniform in presentation, or they are not coalescent, they are scattered, and different densities are seen in the upper zone predilection. Fewer the mid zones. This is a contrast enhanced CT really to search the within uptake, the contrast uptake of a lesion suspected to be a mass or not in the lungs. So in this case, we see that there are opacity in the upper lobes, and these are the peripherally and plurally based lesions are seen in the lung fields. This is classical presentation of the COVID-19 pneumonia. This is a CT film. In X-ray, we used to get this type of overlapping consolidation as a density, not that sharp defined here. This is another CT scan, and this coronal film is seen here. These are the peripheral lesions present in the posterior aspect of the COVID pneumonia, and there is volume reduction of the left lung seen here. So this is the pattern of presentation in COVID-19, and there is basically no effusion in relation. There is rarely adenopathies or pneumonia. Usually they are not present. Another differential diagnosis is MERS. The MERS is the another COVID outbreak happened during 2012 September in the Middle East. And how you can differentiate a COVID-19 and a MERS-CoV. This is the X-ray of the MERS. And this X-ray is this X-ray is seen to have dense opacities present in the left mid and lower zones, and also part of upper zone, and the right paracardiac density. See, this X-ray has got asymmetric distribution of the density, and the groundless opacity is not that prominent. There is increased density, and consolidation is a priority issue here, and there is usually associated effusion, and adenopathy is dense and nodular opacities in the upper or lower zones with a predilection to the lower zone, and the cavitation is a fissure. Usually effusion is very common, and there is nodal involvement. And this is all about our today's presentation. I am some sort of sick. I cannot continue much more. Thank you. And if you have any question, I shall try to answer. You can ask me in the messenger.
আসসালামু আলাইকুম ম্যাম। ম্যাম, there is no question. আপনি যদি চান শেষ করে দিতে পারেন।